The authors have no financial interest in this presentation. As days turn into nights, Dr. Holmes bides his time at 221 Baker Street this winter with a sense of utter boredom. He walks up his stairs every evening to his study, waiting for a case so elementary yet so mysterious. Wait, could this be it? Dr. Holmes received an email. A mystery for phaco-refractive surgeon is treatment of pre-existing astigmatism, which accounts for almost 87% of patients. Astigmatism, if left untreated, can lead to one of the most dreaded complications, that is, an unhappy patient. Cataract surgeons all over the world have multiple questions on how to treat patients with pre-existing astigmatism. Intrigued after reading the email, Dr. Holmes then entered his mind palace. He started thinking of a stepladder approach, which is normally used by all cataract surgeons to manage astigmatism. The first question which was asked is, how important is topography in planning toric IOL? To answer this question, let's take a case example of a 60-year-old male with 1.4 diopter cylinder. The toric IOL was planned in this patient by using the online calculator. IOL was implanted at the plane achieved by the calculator. However, it came as a shock when post-operative cylinder was 3 diopters in spite of the IOL being aligned correctly. After checking if all the boxes were correctly ticked, we found that the answer lied in the curvature map. The patient had an irregular astigmatism of 3.2 diopters pre-operatively. Thus, an accurate reading of topography with knowledge of Bellin-Ambrosio display map and the EKR map helps us in planning precise toric IOL implantation. But is topography the absolute answer to all our questions? Here is a case of a 42-year-old female with a PSC cataract and a -2 diopter astigmatism. The topography showed with the rule astigmatism and no irregularity, but on seeing the aberrometry map, it showed higher HOA values. Post-op, the toric IOL was well centered. However, the patient was still unhappy. Residual cylindrical astigmatism of 1.2 diopters was seen post-operatively. On seeing the biomechanics of this patient, the deformation amplitude was at a higher site, that is 1.45, showing weaker biomechanical strength of the cornea. Looking at this example, we can thus infer that biomechanics also plays an important role and should be included in the pre-op workup of toric IOL planning. The next question which was asked is about the importance of posterior corneal astigmatism. In literature, it is reviewed that posterior corneal astigmatism plays a very important role in toric IOL. Till recently, the online calculators assumed a constant ratio, but with the advent of Baylor's nomogram, which took into account the posterior corneal astigmatism and final effective lens position, posterior corneal astigmatism is now included in many of the online calculators for toric IOL planning. If posterior corneal astigmatism is ignored, it can lead to overcorrection in with the rule astigmatism and undercorrection in against the rule astigmatism. The next question was about axis marking in case of toric IOL. It is a colossal waste of precise planning if toric marking is not accurate enough. Just a simple error in non-alignment of the forehead with the headrest while marking axis during toric IOL planning can lead to a change in cylinder by 1 diopter and 10-degree rotation in the axis. Thus, for appropriate toric IOL planning, a 0-180-degree reference axis is marked preoperatively in a sitting position, as supine position leads to cyclorotation in a range of 7 to 10 degrees. To deal with errors in axis marking, a number of image guiding systems are now available and provide real-time intra-op axis guides for correct IOL implantation. A dilemma which we can face is, what if the patient does not want or cannot afford a toric IOL? Thus, looking at this case example of a 58-year-old female with cataract and a cylinder of 1.36 diopter at 177-degree axis, a penetrating OCCI was planned for this patient. Post-operatively, the cylinder on A scan was 0.68 diopter at 108 degrees with a vision of 6 by 6. Thus, a well-performed OCCI reduces astigmatism by 0.7 diopter and can lead to better results. We have a number of corneal incision-based options like astigmatic keratotomy, femto-assisted astigmatic keratotomy, limbal relaxing incisions. We can use number of nomograms which are available online freely and plan the incisions accordingly to manage astigmatism. Thus, Dr. Holmes rightfully solved all the queries of ophthalmologists all over the world. Hence, mystery solved. He has finally deciphered the enigma of astigmatism preoperatively in cataract surgery.